Hi, this is Elliot Fishman, and welcome to part 2 of our talk on anterior mediastinal masses. We left off last time beginning to talk about the thymus and the range of pathologies. I mentioned that one pitfall in the thymus is thymic hyperplasia. Now, the thymus varies, as we said, with age, and it typically gets smaller, and past age 25, you typically don't see it. Therefore, when you see a thymic mass, you're not thinking hyperplasia, you're thinking tumor, be it thymoma or something else. The thing about the thymus, however, is it's variable in different patients. When you talk about hyperplasia, it's typically arrow-shaped or triangular. It's often of low CT attenuation, often has a lot of fat. So some patients have thymic hyperplasia, and it's sort of not to worry about. But other patients get thymic hyperplasia as a rebound from stress. Classically in chemotherapy, in the beginning of CT, there was often a confusion. Is this recurrence or is it thymic rebound, thymic hyperplasia? And those of us who learned about that were able to make the right diagnosis in nearly all cases based on size, shape, and relationship to treatment. And it's not just from chemotherapy, it could be radiation therapy, steroid treatment, recovery from burns or other injuries, or in other processes as well, such as systemic diseases like myasthenia gravis or collagen vascular disease. So it really is somewhat of a challenge. Remember, as we say, with thymic hyperplasia, it's going to be triangular shape and low density. We talk about things like thymic cysts. Those are other possibilities, but they're truly cystic. Water density may have some areas of higher density, but they're not going to have that very nice thymic shape. They typically will look like a cyst. Now, the biggest challenge you end up having, of course, is that patients with thymic cysts, it can be a challenge at times to differentiate from a process such as thymic cystic components in a thymoma. They can be cystic or in some of the different other tumors that are malignant in the thymus. So it can be somewhat challenging. And I'll show you some examples looking at all of that. Here's a patient who's 12 years old, and you can see a prominent thymus. But that thymus is normal for age, right? The patient's 12. The patient does have adenopathy, pretracheal zone and around the trachea, middle mediastinum and posterior mediastinum. And these look like nodes in part calcified. There are also hilar nodes. You can see the compression of the bronchi by the subcarinal nodes. But what does this patient have? This patient had two things. The patient had infection or inflammatory disease, which ends up being, when you look at all of the images and the airway narrowing and the compression and the adenopathy, was histoplasmosis, which is a great diagnosis in a young patient, unusual diagnosis, but then the normal thymus. Again, age 12, that's normal. Age 20, it's probably okay. Age 30, I have to worry about something else going on. Very, very important. Another example, here's the thymus. It's a bit older of a patient, but it's an arrowhead configuration. There's low density, a little bit of vascularity. That's thymic hyperplasia. Very nicely shown on these images. And here it is in the sagittal view. Another patient, thymic hyperplasia, not quite that perfect arrowhead, but you can see from here, it's like fat attenuation. So with patients who have thymic hyperplasia, often you'll have diffuse fatty infiltration. Sometimes it maintains that perfect arrowhead shape, and sometimes, like in this case, it doesn't. But this is the look of thymic hyperplasia. Again, nicely shown in the sagittal view. Another example here, this patient was about 20-ish. Again, kind of arrowhead shaped, low density, some fat within the process. So again, you got to be thinking thymic hyperplasia. There it is nicely on the coronal view, nicely seen sitting there on the sagittal view as well. And a great example of thymic hyperplasia. Now, what about this case? This patient's in their late 30s, It looks like a perfect arrowhead. This patient's 20 or 25. I'm still saying thymic hyperplasia normal. But at age 35, you begin to wonder. And this patient did present with headaches. This patient was worked up. The rest of the chest looks okay. Just this thymus shows hyperplasia. Nicely shown on the volume rendering, but especially nicely shown sitting here on the cinematic rendering. Here's the thymus gland, nicely shown here. Again, right between the two lungs, sitting perfectly. Anterior mediastinum, triangular shaped, fatty infiltration. What do I do with this? Well, because of the patient's headaches, the patient was worked up further, and you can see the sella is enlarged. The patient has a mass on the CT. There it is. Look at the large sella, right? There's a lesion there on the sagittal CT, which you can see very nicely on the MR imaging as well. And so now we have a patient with a mass in the sella, which was a pituitary adenoma. Pituitary adenomas can secrete growth hormone. Growth hormone can lead to patients developing thymic hyperplasia. So again, you put it all together, the thymic hyperplasia, I'm not sure it helped you make the diagnosis of a pituitary lesion, but it made you wonder what was going on in this patient. And of course, the headaches led to a CT and an MR, and the correct diagnosis was being made. Now, in this article by Hayron talking about CT and MR and the accuracy of thymic masses, CT tends to be the workhorse. MR can be very helpful. We talk about different lesions from hyperplasia we looked at. We talk about other things from cysts, to epithelial tumors, lymphoma, and the like. So again, we now have a good feel of what we're thinking about with thymic hyperplasia, and we'll go forward and look at other things like thymic cysts. And again, just to remind you, with thymic hyperplasia, there's often a history of stress or symptoms that lead to an investigation, like the patient with the patient's brain mass in the sella. Now, again, thymic hyperplasia, think of Graves' disease, think of rebound post-chemotherapy, and myasthenia gravis. So again, three very important differential diagnoses. So let's move on from there. And again, remembering the potential problems with thymic hyperplasia, and look at some other benign lesions. And I think when we look at other benign lesions, the one I like to think about most is thymic cysts. Now, I have to admit we don't see very many thymic cysts. We sometimes see small ones, maybe a centimeter in size in the anterior mediastinum, looking like a small node. But you can also have larger ones, which can be challenging. And again, think about all of these factors, and I give you some references here. But again, the things we think about in the thymus, the density, water density, vascular, is it fat infiltration without significant enhancement? Is there calcification or not? Now, in this case, you see there's a lot of fat in the anterior mediastinum. There's these little nodule densities here. And you could say this is thymic hyperplasia. That is indeed a good thought. This patient is older. Maybe the patient just has some remnant thymus gland there. But what this was is a thymolipoma. It's a rare benign tumor composing fat, mainly. Average age, you can see, is in their 20s. They can be very large. They can look identical, and the age is good, look just like a thymic hyperplasia, but it has more fat within it and usually has more mass effect and doesn't have that classic triangular or arrowhead configuration. So it's a really, really interesting diagnosis. Take a look at it again. It's an important diagnosis because it's a leave-alone diagnosis. If you recognize it, you leave it alone and move on. Just a very nice example. Again, you don't see that sharp margins of thymic hyperplasia. Has a totally or pretty much different appearance to it. Here it is on the sagittal view, very nicely shown. Now, I mentioned thymic cysts. Now, thymic cysts are going to be benign. And again, the key is not to confuse it with malignancy. Thymic cysts do not look like thymolipomas. They do not look like thymic hyperplasia. But you can be concerned about other possibilities. The average length, it was 17 centimeters in this one article. Now, they do enhance a bit. Most of the ones I see are smaller, but they can be huge, which this article shows very nicely. Thymic cysts are considered to be a relatively rare type of anterior mediastinal masses. They're reported to account for about 1 to 3% of cases, but we do pick them up because they're not always cystic, and they can be very small, although, as I mentioned from the last article, they also can be very large. So as we look further, this article by He also makes the point, most of the existing literature reports that thymic cysts are triangular or round in shape. My experience is typically they're round. They can be very cystic, but sometimes they're simply soft tissue density. No one has really super large series, which is why it's very variable. I think also they change over time, so depending when you scan the patient, at what age, it may look a little bit different. And again, the main concern is a differential diagnosis of thymic cyst and a cystic thymoma. Again, larger thymomas can be distinguished due to their uneven enhancement, but sometimes thymomas, particularly when they're well-defined and less aggressive, can have cystic components, and there is overlap. And that's why there are times patients will get surgery for what seems to be a thymic cyst in retrospect, but up front it was very, very concerning for a thymoma. Here's a good example of a thymic cyst. Mass anterior mediastinum, kind of low density. Remember, what else did we look at before? We looked at a node, we looked at a parathyroid adenoma, but it's not going to be that. So a well-defined water density thymic cyst is good. You can see it there on the coronal and sagittal view. Here's another case of a thymic cyst, and in this case it was partially calcified. We don't talk about thymic cysts typically as calcifying, but they can be. This was eventually removed. I'm not sure why, but it was a thymic cyst. Probably at some point it bled, which would explain the calcification. And here's a more worrisome one. Large cystic lesion, eccentric. You would track it downward to make sure it wasn't a pericardial cyst, which it's not. It's not a bronchogenic cyst, bad location. But it could be a cystic thymoma. It has some rim enhancement, very minimal. You could think about lymphoma even, cystic lymphoma. You could think about a germ cell tumor. But, it's challenging, but this was a thymic cyst. And to me, when they get large, like this case, it can be a more difficult diagnosis. You can see there's some rim enhancement, which always makes you worry, but this was a thymic cyst. What about this patient with chest pain? Here's an eccentric cystic lesion to the right of midline. Looks very much like the last case, but doesn't seem to have enhancement. You can see it's over 13 centimeters. It's water density. You can see on the coronal view, it literally fills the anterior mediastinum going to the right of midline, but literally from upper mediastinum down to diaphragm. You can see its extent on the coronal and on the sagittal views. You can see it really nicely. The water density looks like stomach. Red on cinematic rendering is fluid. So we got to be thinking this is a cyst. You could think about a very large pericardial cyst. You could think about a mediastinal cyst. It's not a great location for a bronchogenic cyst or esophageal duplication cyst. So what was this? It was a thymic cyst. Good example of a 13 centimeter lesion, water density, often eccentric. The few thymic cysts I showed you that was small was centrally placed. When they get larger, it's not a surprise. They tend to hang to one side, more commonly hang to the right. Okay, so those are benign, right? Thymic hyperplasia, thymolipoma, and thymic cysts. Now, what about malignancies? Thymoma is the one we all think about. It's the most common anterior mediastinal mass in adults. They're often asymptomatic and incidentally discovered, but patients can present with symptoms ranging from cough to dysphagia to chest pain. CT usually reveals a homogeneous soft tissue mass with relatively sharp borders and a lobulated round or oval shape. Occasionally calcifications or areas of necrosis can be seen. We talk about clinical history because it's classically associated with myasthenia gravis. Up to 50% of patients with thymoma do have myasthenia gravis. However, only 20% or less of patients with myasthenia gravis actually will have a thymoma. We talk about other types of tumors arising from the thymus gland besides thymoma. We talk about thymic carcinomas and thymic neuroendocrine tumors. They're large masses, often solid, and most of the time it's really hard, maybe I should say impossible, distinguishing between that and a thymoma. There's a lot of different comments about this. Again, the challenge also will be on the benign side, that sometimes thymic cysts don't look that benign, and they can be confused with thymomas or thymic carcinomas. Less frequently thymic neuroendocrine tumors, because then they tend to be more vascular. We mentioned about numbers. Thymoma predominates in the middle-aged individual, infrequent in children, again associated with autoimmune disorders and myasthenia gravis. Okay, very important. Thymic neoplasms are rare tumors, less than 1% of adult malignancies. The primary epithelial neoplasm of the thymus, including thymoma and thymic carcinoma, are the two main lesions. Thymic carcinomas tend to be more aggressive, but it's still a very uncommon tumor in the scheme of things. And again, age does help. It's usually an older patient, usually 40 to 60, and not going to be seen in children. The whole thing about symptoms, myasthenia gravis, when CT first came along, I remember in the beginning we did lots of patients with myasthenia gravis because everybody with symptoms of myasthenia gravis got a CT scan, and we found lots of thymomas, particularly smaller thymomas. Between 30% and 50% of patients with thymoma have myasthenia gravis, as I said. 10% of patients with thymoma have hypogammaglobulinemia, and 5% have pure red cell aplasia. So very important. Thymomas also are associated with autoimmune disorders. So if you're looking at a patient with autoimmune disorder and you're looking at chest, abdomen, pelvis, look very carefully at the anterior mediastinum. Now, when thymomas occur, they can be well defined, but they can involve vascular structures by direct invasion. You can have pleural involvement or pericardial involvement. You can have implants, and drop lesions on the pleura is one of the challenges with thymomas, particularly malignant thymomas. The way you can tell thymomas are malignant is they become invasive, or they have implants on the diaphragm, the pleura, or on the pericardium, a very classic appearance. Now, thymomas are often eccentric. Here's a nice example of a thymoma. Soft tissue density well defined. Here it is again in another set of views. Again, what else could you think about? Lymphoma as a possibility. It's not going to be a teratoma. It's not the thyroid. So thymoma is a good thought. And seeing the pericardial effusion on the lower scans, but more importantly, the pleural effusion would concern me. Here's another case of a thymoma, incidental finding. We were looking at possible aortic aneurysm. The ascending aorta is top normal, but again, well-defined. This could be a thymic cyst, to be honest with you, because it's water density and well-defined. And this is one of those examples where thymic cysts and thymomas can look very, very similar. And I can't really give you any helpful advice on how to separate the two. Thymomas, I mentioned, are often eccentric. Here's a larger thymoma with some faint calcification. Also, you can see it appears to involve some of the soft tissue planes. And as you look carefully, it extends down toward the pulmonary artery, but you would worry about potential invasiveness in the fat in the anterior mediastinum. Just a really nice example of early invasive thymoma. Here it is on the 3D reconstructions. Another example, more extensive infiltration of the anterior mediastinum. You can think about lymphoma, but what you see here is pleural implants. When you see pleural implants, I move away from thinking about lymphoma or teratoma, and I go to thymoma, and I go to malignant thymoma with implants on the pleural surface, very nicely shown there. In this patient who had chest pain, and again, the infiltration of the anterior mediastinum is clearly seen. From all the features, the mediastinum as well as the pleura, this is an aggressive thymoma. Very nicely shown. Here's a few more images. And here's the sagittal view. This case, on the sagittal, you see the punctate calcification. And I mentioned before, thymomas can indeed calcify, but you don't have really coarse calcifications. Coarse calcifications, anterior mediastinal mass, I got to think about lymphoma that got radiation therapy, but also think about teratoma, and we'll come to that. But just a really nice example showing you some of the 3D images of the extension of this patient's thymoma and its infiltration. And again, this has all the hallmarks of a malignant thymoma. This is an unusual case. The patient has chest pain. It's a younger patient. There's a mass by the diaphragm pushing on the patient's SVC as it comes down to the atrium. What's going on here? Could this be a duplication cyst, a pericardial cyst? Could this be some type of cystic tumor? It's really not an anterior mediastinal mass, though it does track a bit upward, but it's mainly near the heart. I'm thinking of all sorts of pericardial type processes. You can see it on the volume rendered view, where you see the relationship between the heart and this lesion. So again, you're thinking about things like, even could it be a cardiac tumor, lymphoma, angiosarcoma? They're usually more invasive, but you at least think about that. But what could this be? Well, this was a great case, particularly as patient was really young, was a teenager. This was a thymoma, believe it or not. There it is on the cinematic rendering. I mean, it's impressive because it's so cystic, but it's so low-lying. It's really abutting the diaphragm and abutting the heart. It's really near, but not coming from the patient's anterior mediastinum as we typically would think about it. You can see some of its aggressiveness here when I look at the cinematic rendering, but it's a most unusual and most atypical case. And it was an 18-year-old with a thymoma. What a great case. What a challenging, difficult diagnosis. Now, I mentioned in the last case invasive thymoma, and you can see that over here as well. So let's do this. I want to talk a little bit more about invasive thymomas, make a few more points, and time is running late. So let's stop here and let's come back and pick up our talk, talking about invasive thymomas. See you soon. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.